story, something to get off my chest.
Okay, welcome to today's presentation. We're going to continue the pharmacology theme. This time we're going to be focusing on all the pharmacology that affects common disorders within the gastrointestinal system. So the disorders that we're going to look at today in particular is GORDs. So for the Americans in the room, don't be afraid, it's exactly the same as GERD. It's just what we call it in Australia. Peptic ulcers disease, constipation, diarrhea. With diarrhea, we're not going to be focusing on the antibiotics given to treat the microbial infection. We're just going to be looking at the anti-diarrheal substances and when to give it. And then we'll look at nausea and vomiting to finish it off. Okay. So to start off, we'll do a little bit of anatomy physiology of the actual stomach. So then you have a good understanding of how the processes work, so then when you look at the disease process, it makes more sense why it causes pain. So looking at the stomach, it's easy to tell that there's a series of layers of muscles that essentially surround the stomach. Now there's different factors that affect the way these muscles contract, which we'll go into later on with the disorders. And if you focus on the area known as the fundus, which is the bottom, you'll notice the shape of it is called the rugae. So what that means is it's actually layered in order to increase the surface area to volume ratio. The reason that's important is obviously the stomach acids are highly acidic, so increase the surface area with the rugae in order to protect the underlying tissue. The other thing to note is what you can't see, but up around the esophagus area, you essentially have an internal matrix that crosses over itself. Sort of like a longitude and latitude matrix that cross over itself, and as food passes through it, the fibres spread in order for the food to pass, and then it closes off in order to protect it from any gastric juices coming up to the esophagus. Okay? Other thing that's important to know about the stomach is it's not designed to absorb any of our nutrients. Okay, so the absorption rate of the actual stomach is pretty much none. There's two known substances that are absorbed by the stomach, and that's acetylic acid and ethanol. Everything else essentially gets absorbed in the small and mostly the large intestine as it goes down. So the stomach is purely involved in the mechanical and chemical digestion of food. If we take a closer look at the mucosa itself, you'll know that there's a series of different layers that are around the stomach. So this is looking at just a common area around the fundus of the stomach, and you'll see the top layer is essentially a high bicarbonate layer that essentially protects it from the surrounding acids. So the gastric juices in the stomach have a pH of around 1 to 2. Okay, so it's very, very acidic substance, these gastric juices, but the mucosal gel is highly bicarbonate and has a pH of around 7. Okay, now the bicarbonate layer is there to protect the underlying cellular structure and the muscular structure from the attacks from the acids. So the things that attack the mucosal layer is obviously your hydrogen being your main acidic substance, essentially tries to degrade, breaks down the actual mucosa alkalinity, and pepsin is a digestible enzyme. So pepsin will bind to the mucosal layer and start digesting it the same as it would if there was food there. Okay, so that's what pepsin does. Now, the specialised cellular structure of the epithelial, you'll see how they're pits. So these are what's known as gastric pits. Now the reason these are important is along the top of the epithelial layer, they're essentially regenerative cells. Okay, so they're involved in the reconstitution of the mucosa, things like that. But when you go down into the pit itself, that's when you get specialised cellular structure, like your parietal cells, your endocrinological cells. They're all in that pit, really protected by the mucosa, and each of them have specialised ability. Now you'll see the microcirculation below that again, and the reason that's important is it sort of gives you an indication of why absorption is so bad in the stomach. Okay, because in order for nutrients, electrolytes, or anything to pass through the mucosal gels, through the epithelial cells, into the microcirculation, okay, is obviously not very likely. It's only those substances that have high penetrating ability will actually get through. Now, in turn, when there's associated gastric swelling, you'll see that it's usually a long-term process. So it starts with the microcirculation dilation from prostaglandin, causing inflammation of the epithelials and degrading the mucosa before you'll actually get that gastritis effect. Okay. Now, heading back to the substances that are pushed into the actual stomach to produce gastric juices, most of them come from what's known as the parietal cell. So the one that we're going to focus on mostly is hydrogen ions being pushed in to the actual stomach. Now, hydrogen is very important in the gastric acid production, obviously, because pH stands for power of hydrogen. The more hydrogen you have in the solution, the more acidic it is. Okay? Now, it has a nice balance with the bicarbonate layer, and essentially what happens is you have what's known as a hydrogen and potassium switch at the parietal cells. So for every hydrogen ion that goes in, a potassium ion will go out in order to balance that ionization within it. Remember, everything in the body needs to be neutral. So for every positive, you have to lose a positive or gain a negative. Basically the way it works. Now, looking at the parietal cell, it's also known as the proton pump. If you've ever heard of that, there's a number of stimulus that can affect the parietal cell, pushing hydrogen into the actual stomach. Now, this is the basis of all of your antacids medication, is essentially blocking one of those substances or affecting the actual hydrogen itself. So the main perpetrators, if you will, is you've got your acetylcholine, okay, so your muscarinic receptors essentially will put acetylcholine, will release hydrogen. You've got your histamine effect as well that causes essentially the same thing, and then you've got another substance called gastrin, which is a hormone that causes the stomach to contract itself. So that's the main ones that will essentially stimulate the release of a hydrogen ion through the parietal cells. Now, another substance that most people don't realise plays a massive part in digestion and essentially aids stomach motility is your serotonin. Okay, now serotonin is actually produced and stored in the stomach and the intestines. Okay, a huge abundance of it is stored and created from the stomach. So 40% of all your circulating neurotransmitter serotonin is produced from your stomach. Okay, which is surprising because it plays very little in our basic understanding of serotonin. We don't often attribute it to anything to do with the stomach. Okay, it's always mental health factors or depression, anxiety, that sort of thing that you would link serotonin to. Okay, now serotonin is highly susceptible to a number of stimulants. Okay, much of the ones we've already mentioned. Then it's also released by baroreceptors as well. So when the stomach essentially feels pressure, when it actually grows and it feels like it's full, you release serotonin as well in order to aid in that gastric process. Now, serotonin, unlike the other ones that were involved in pumping in hydrogen ions to aid in that breakdown of food, serotonin is involved in secreting essentially the fluids associated with digestion and also increasing that peristaltic movement. Okay, so that's what serotonin does for the stomach. Okay, so knowing that, looking at it, obviously effects of serotonin, if you have too much serotonin, you're going to increase the amount of secretions and increase the motility, which you'll end up with diarrhea. In turn, if you have too little serotonin, then you'll end up with constipation. Okay, so it plays a massive role. So just basically for your introduction, there's obviously a lot more you can learn about serotonin, but we won't be focusing on any serotonin-based drugs within this presentation. But when you start looking into them, it makes more sense why a lot of the side effects are linked to the abdominal region. Okay? Rightio. So first two disorders, we've got GORDs and we've got peptic ulcer disease as well. So GORDs is exactly what it is. It's gastric esophageal reflux disease. It's essentially where the gastric juices of the stomach push up into the esophagus and end up degrading the walls of the esophagus, sometimes all the way up to the throat, and you'll end up with burns and irritation at the back of the throat as well. So that matrix that I talked about before is essentially destroyed over time by large amounts of highly acidic environments pushing against it, and once it's destroyed, your esophagus has lost its process to protect itself. So things like having a big meal, that increases the hydrogen being put into it. Lying down straight after the food is obviously going to increase the amount of gastric juices that can flow into the esophagus. These little things, that's what causes. Now, unlike the stomach, it is not the esophagus doesn't have that rugae layer, and so it doesn't have that high surface area to volume ratio, so it's extremely susceptible to acidic damage. Okay, so hydrogen destroys the esophagus, and also your pepsin destroys the esophagus as well, because it just starts digesting you as though you were food. Now, the main problems that happen with GORD is obviously it's discomfort. You feel like indigestion, you have that sort of pain, but over time you can end up with things known as esophageal varices, which is essentially, easiest way to put it, is hemorrhoids of the esophagus. That constant irritation from acid and the minor repair, and then the acid, minor repair, essentially makes the body adapt with bringing those vessels, that microcirculation, closer to the surface and enlarging like scar tissue. So now you have large vessels close to the esophagus, and if they rupture, you'll have a massive hemoptysis. Okay? So you'll be vomiting up huge amounts of blood. Makes it very, very difficult to intubate or care for it. Okay? Usually treated by putting a big plug on the top, knocking the person out, and then essentially doing surgery from there. It's a really nasty one. And then, of course, your esophageal cancers can occur as well. Okay? Now, peptic ulcer is a similar process. The only reason we say peptic instead of gastric is obviously you can have it of the stomach or the duodenum. Okay? Or technically you can have an ulcer in the esophagus. They're all known as peptic ulcers. Now, the way they occur is usually by the help of a microbe that you'll learn about soon. But essentially it finds a weakness in the stomach, and then the pepsin and the hydrogen essentially start degrading that rugae until you get down to the epithelials. It easily eats through the epithelials, you get to the muscular layer, and then you start getting bleeds within it. And the idea of a lot of the treatments is to reduce that acidity in order to repair the actual walls around it. So the stomach and the esophagus are able to repair themselves, but you need to be aware of the mechanisms that's occurring so you can educate the patients on the best way to take the medication to prevent long-term effects. Okay? So, right off the bat, the treatments. Simple treatments right from indigestion, GORDs into peptic ulcers. Okay, so we essentially have a layer of things in our arsenal that we can use. So your antacids, your H2 receptor blockers, your proton pump inhibitors, your mucosal protective agents, and then your antimicrobial agents. Now we can also use a anticholinergic as well that you'll learn. Okay, in some cases it's essentially used when the other ones, or used in conjunction with the H2 receptor blocker, which we'll look into as well. So just keep that one in mind. So on to the pharmacology. We'll look very simply at your antacids. So they are simply involved in either attracting chloride or removing hydrogen. Okay. Now the problem with having that mixed together, hydrogen and chloride, in the stomach is essentially they will bind and they'll produce hydrochloric acid. Now it's hydrochloric acid that is needed in order to turn pepsinogen into pepsin. Okay, so if you can stop the hydrogen, the amount of hydrogen in there, you're going to reduce the acidity. But if you can also stop the bonding of hydrogen and chloride, then you're also going to stop the production of pepsin. So you reduce the overall acidity and you reduce the overall pepsin, the two destructive agents that are essentially found in the stomach, causing the problems. Now when we're talking about systemic antacids, if someone has systemic acidosis, we use buffers like your sodium bicarbonate. And now obviously that's a slow push. To push it fast will actually cause a pseudo-respiratory acidosis, but a slow push will absorb a lot of those acids in the body. Now we can't just pour sodium bic into the stomach because the stomach's a little bit different. So we need a non-systemic antacid, and usually they're a mixture of aluminium, magnesium, sodium chloride, and essentially non-digestible agents as well. Okay? And what they do is they'll essentially soak up hydrogen and stop the bonding between hydrogen and chloride. Now, if someone has renal dysfunction, you need to be careful giving these sort of things because you're essentially putting in a large amount of cations, or a large amount of aluminium hydroxide into somebody that can't excrete it. And that can cause, obviously, a massive ion gap problem, okay, with your positives and negatives, and therefore cause ongoing metabolic alkalosis or acidosis as well. So anyone with renal failure, most people think, well, answer and things like that are like, well, have they just taken? But you need to consider the renal impairment as a thing. Okay? Now, if you have something with magnesium in it, so if you're picking one of the antacids with magnesium in it, one of the side effects, just to tell someone, is they can get diarrhea. Okay? That's just what happens. Basically works as an osmotic agent. Okay? So that's first off, right? Now, we've all used these, we've all seen these. They're usually used in conjunction for minor things like heartburn, indigestion. If someone has a peptic ulcer, then you generally use this as a supportive agent, if anything. Okay, so moving on to the true agents that stop hydrogen coming into the body, we have H2 receptor blockers. Okay, so H2 being histamine. Now there's two different types of H receptor blockers. There's H1 and H2. So H1 is usually associated with the histamine response on your skin, your allergies, things like that. Okay, now H1 can still have, a lot of those H1 receptor blockers can still have an effect on the stomach. Okay, ranitidine, for example, if you were to use that as a topical agent, it still works as that sort of anti-itch, that sort of anti-irritant side of the house. But in this case, it's being used to stop hydrogen coming into the stomach at the parietal cell. So it's stopping that stimulus coming in that will instigate the parietal cell, the proton pump, to push in the hydrogen ion. Okay, that's what your H2 receptor blockers do. Now, they're not the strongest of all the receptor blockers. Okay, they're about equal with your acetylcholine one that we use for this, so your muscarinic receptor blocker. But it's still not bad, especially if someone has a sensitivity to proton pumps or anything like that. So it essentially can suppress up to 70% of your secretions for around that 24-hour mark, so it's not bad. So the next one that we'll look into is looking mostly at that next stage. So not looking at blocking the stimulus that causes the parietal cell to push in the hydrogen. This one acts directly on that proton pump. So directly on the area that pushes hydrogen in and removes potassium out. Okay, called the proton pump. Hence, proton pump inhibitor. So this will basically very strongly bind to that proton pump and block any movement in and out of that actual area, which in turn reduces the whole amount of acids that are found in the stomach because you're not getting all this hydrogen, and essentially allow for that healing factor to occur. Now you can remove, it's like 95% of all hydrogen that comes into the stomach can be removed for up to 48 hours just from one proton pump. So it is much, much stronger than your H2 receptor blocker. Now the thing to note with a lot of these, especially if you're using any of these drugs for things like peptic ulcers or pretty bad GORDs, the ones that actually cause destruction, is you need to take it for 1 to 2 months. Okay, sometimes even 3 months depending on how bad the actual peptic ulcer is. Now the reason for that is the proton pump or the H2 receptor blocker is going to reduce the amount of hydrogen that gets put in, which in turn will reduce the amount of pepsin that is produced, which allows that area of your stomach to heal. Now what most people do, because most people are stupid, is they'll essentially wait, they'll take a couple of doses of tablets, they'll start getting the healing process, so the mucosal layer and everything will start healing again, And with that, the pain will go away. Once the pain has disappeared, the human will go, I'm not taking this anymore, I'm cured. Stop taking it, and then the acids will easily destroy that newly developed layer. And they go, oh, pain, that's right, I have something for that, and they'll take it like it's paracetamol or something, or that sort of thing. But the whole idea is you want to take it for the stomach and the peptic ulcer to fully heal, so then you won't need it again. So that's what you need to educate your patient on. The dangers of taking it intermittently and taking it like a pain relief is essentially each time you cause that cellular structures to repair and then damage and then repair themselves, what you're actually encouraging the body to do is to go through something known as rapid adaptation to new environments. Okay, and that is the basis of what causes neoplastic formation. Okay, so that is the cause of most of your gastric cancers, is essentially using these sort of things incorrectly. Like destruction, minor repair of peptic and esophageal ulcers. Okay, so it's very, very important to do it. Now, what sort of drugs do we know that contribute to GORDs and PUDs? What's a drug that everybody takes, looking at Americans mostly, that causes these sort of things? Motrin's one of them, definitely, but what do you reckon, Taz?
Oh, I like your anti-inflammatories.
Yeah, all your non-steroidal anti-inflammatories cause essentially an increase in acidity and increased probability of getting GORDs and peptic ulcers. It's actually the leading cause for the GORDs. Not peptic ulcers, believe it or not, but it's a good contributing factor to it itself. But it's just something to consider, especially if you're taking 1.6 grams of ibuprofen in one hit for a sore knee. But anyway, I'm not here to judge. That's all good. Right, yeah, so that's your proton pump inhibitor from there. Now, just as a summary, because a lot of people like pictures, it makes it a lot easier to understand. This essentially is a segment of your parietal cell. So looking over here, we have our connection between hydrogen and chloride joining together. Remembering I mentioned before that it's the hydrochloric acid that causes pepsinogen to become pepsin. So your antacid soaks up the hydrogen and stops that bond. That's what it does. That's where that works. Now, your receptor blockers, either acetylcholine and histamine receptor blockers, okay, they work over the other side. They're basically the stimulus to the parietal cells to release hydrogen at the proton pump. Now, that's why they're about 70% effective. They're not as effective as the proton pump, okay, because we can't stop gastrin. Okay, that increase mostly to do with the actual movement and strength of the contractions, but it still has that secretory effect. Now, if you were to take a histamine and an anticholinergic, then you'll get more of an effect, but there's also more side effects associated with it. If you take a proton pump, then essentially we're blocking it right at the source. Okay? Now, obviously, your omeprazole or emeprazole, they're your most famous. Okay, the geniuses in marketing essentially waited until their patent was almost up for the omeprazole, and then they magically created the emeprazole in order to hold on to the patent longer, and all of a sudden it's the most popular proton pump inhibitor going around. Now, obviously there's pantoprazole as well, which is good because it also has that sort of IV ability to get it in there that little bit faster. Okay? So that's the breakdown of how those acid reducing therapies work. Okay? Different therapies for GORDs and esophageal is your mucosal protective agents. Now, believe it or not, Australia is not huge on these. Now, we do use them, but places in Europe and the US, they are obviously a lot more favourable for these sort of things. Now, it's not that there's anything wrong with any of these particular things. It just can have some pretty bad side effects if you're not using it correctly. So what a lot of these mucosal protective agents do is essentially they create a huge fibrous matrix over the area of destruction, therefore replacing that mucosal layer temporarily and alleviating the pain. Now, they're not usually associated with the healing side of the house, it's just that relieving of pain. So they're good for reflux, they're good complementary type drugs, okay, because they're essentially protected from the existing acid in the stomach whilst the overall acidity is being reduced. So they can be used for that. Now the two most common ones is obviously the Carafate and your Pepto-Bismol. Okay, I'm pretty sure Pepto-Bismol comes in 4-gallon drums in America because it's that popular. Okay? It's after every meal, you take your Pepto-Bismol and
Fill your car up, you fill yourself up.
and you're good to go. Yeah. So it's actually quite a good substance, believe it or not. It's effective. There's even studies out there that suggest it has a lot of assisting properties in killing your H. pylori as well as having that protective layer. Now it can be used for obviously your acidity, it can be used for discomfort, cramping, essentially any discomfort of the stomach. Your Pepto-Bismol has some sort of effect. Your Bismol crystals basically have the effect on there. Now the problem is, what needs to be educated is you should not take it for more than 2 months. It should be taken when you have symptoms, not taken as a prophylactic. Okay? So taken only when you have symptoms, not as a prophylactic. And the main risk associated with the Carafate is when it touches an acidic environment, it literally creates a sheet over the area. Now if you were to eat food first and then take it, what can happen is food substance gets caught under that sheet, and then all of a sudden that digestive process sticking on the mucosal layer can actually degrade it further. Okay, so that's why you need to take it before or after, give enough time for that food to dissipate from the stomach. Ready? So there's your mucosal protective agents. The last one we'll look at is essentially your antimicrobial. Okay, so Anti-H.pylori Therapy. So Helicobacter pylori, as mentioned in the antibiotic sort of one, is a bacteria that has a flagellum. Now that's what the tails are on the other side. So it has the ability to swim around the stomach, which makes it notoriously difficult to kill. And what it does is it can swim around, find an area of weakness in those rugae, and then start breaking down the substance. It uses your microbial, uses your mucosal layer as energy in order to reproduce. And then it produces toxin, which causes, let's say the exotoxins produced from the H. pylori causes inflammation, which degrades it even further than that. So it's a very nasty bug, and it's responsible for around 85% of all peptic ulcers are caused by H. pylori. Now, does anyone know the test that is used to find if someone has H. pylori or just another cause of a peptic ulcer?
Like a sheet you breathe into it.
Yeah, spot on. So the sheet that you breathe into is what's known as a carbon-13 test. Okay? So carbon-13 being a well-known isotope of carbon, most commonly being carbon-12. Carbon-13 is essentially what is produced as you are broken down by H. pylori. As you are being digested by H. pylori, you produce carbon-13. As you breathe it out into a bag and pick it up, that's how you get the positive test for H. pylori. Now the way to kill it is you need a lot of combined therapies in order to kill H. pylori. So your amoxicillin mixed with your clarithromycin or with your metronidazole or with your tetracycline is essentially a recipe that you can use depending on how severe it is or the person's allergy. But essentially you will take either an amoxicillin, so penicillin, your beta-lactams, with your tetracycline, and then either metronidazole or clarithromycin. Okay, one of those two. I take them together. The reason for that is obviously, as we learned in the last lesson, they have different effects on breaking down the cell wall whilst also inhibiting protein synthesis or moving into the actual cellular structure and stopping the DNA synthesis itself, like your metronidazole. So that's the answer to the question from the last lesson. What's the other bacteria that we use metronidazole most commonly for? The answer, of course, was H. pylori. Okay? You all knew that already. Now, you can either go with a triple, which is the most common. Okay? The triple therapy is the most common for 7 days. Okay? It's been proven very, very effective over time. Now that's where you take a proton pump inhibitor, like omeprazole, and a mixture of the antibiotics that I just mentioned for 7 days. And that essentially works. It stops the acidity helps it repair whilst killing the H. pylori itself. Now, a new one that has come out hasn't been tried and tested as much as the other one, but there are supporting studies for it. It essentially says that if you add Pepto-Bismol to the triple therapy, you can reduce the regime down to 3 days instead of 7. Okay, so if someone's particularly sensitive to some of the antibiotics that you're given, it may be an idea to try. Okay, but like I said, not as quantified as a triple therapy, but definitely out there in literature as a treatment. Okay. Are there any questions on GORDs, peptic ulcers, or any of the treatments that we give for it? All good? That's Melanie? Yeah, good there. Right now. We'll move on to everyone's favourite, it's constipation. Okay? Very, very common in the military for a lot of reasons. And we're going to have some contributing factors to constipation that's indicative of the military. Dehydration is a wonderful one. We're all dehydrated. Stress? Yep. Spot on.
The
Irregular diet.
the
Beautiful.
MREs that we eat.
MREs that you
Or-
eat. Yep, they're
or
designed as
yes.
highly bulking agents. They are. Yep.
New country is Afghanistan. It's
Yep.
not Syria.
New country, new diet, and you maybe not want to use the toilet as well. So you basically just ignore the need, keeping the feces in there longer. So all things that are very common to the military, especially when you're on patrol and things like that. Okay, so very common disorder. So we'll have a look at the common treatments there for it. Okay, so we've mentioned a whole lot of normal causes for constipation. Now, when you're in the military, all those things are generally higher contributing factors to the rest of the population. Now, the rest of the population that stays in one place is happy to use their toilet, generally better hydrated, those contributing factors reduce. But the number one cause of constipation in the general populace is actually people abusing laxatives. Okay, and we'll explain how that works as we go along. Now, the therapies for constipation, we have a mixture of obviously preventatives to quite simple movements, all the way down to your stimulants that increase peristalsis and your stool softeners. Okay. A visual representation of how each one of those work before we just talk about the actual individual drugs and how you take them is we'll start with the fibrous, so essentially the bulking agents. Okay, so you take food that is high in fibre, because fibre is essentially a large fibrous matrix that can't be absorbed by the body. So all it does is essentially draws and hold fluid in the feces itself. So the more fibre you take, the more formed and larger your actual feces will be. Okay? And it won't allow the body to take away the water, causing it to become constipation. So keeping it moist enough in order to move through the actual bowel. The other advantage to the bulking agent is it will be larger as it reaches the large intestine, and it's the pressure on those baroreceptors that will cause that increase in peristaltic movement. So it actually will increase naturally the movement of the feces itself as well. So that's your bulking agent. Your osmotic laxatives, okay, they're designed in reversing the normal process of your large bowel. So it's a high osmotic pressure, which is obviously going to draw in fluid as opposed to allowing fluid to leave the bowel. The more fluid you got in there, the more slippery of a slope the actual feces have within the large bowel. So it's quite simple. The fecal softening agents, they're involved in actually penetrating the feces itself and creating an artificial lubricant of secretions around the feces. Again, in order to allow it to more easily lube it up, if you will. And then you've got your stimulants, which are involved in increasing peristaltic movement, which grinds or pushes the feces out. Okay, so there's your options. Now, obviously, depending on the severity and the duration of diarrhea, will determine which ones you're going to use. Okay. So we'll start with your bulking laxatives. Now, these ones are great as preventatives. If you are on a medication that is known to cause constipation, if you're going out into an environment where it's more likely to cause constipation, like a cold environment, okay, taking high fibrous substances as a supplement is a very good idea in order to prevent it. If you have constipation for a few days and it's known, you can feel it, you can palpate it. Bulking agents aren't going to do anything. They're just going to increase the amount of feces behind it, and then maybe use it as a barge pole to move the block, but realistically it's not going to do a lot. It's not the best choice for that. Okay? But you need to educate the patients that when they're taking large amounts of fibre, they need to drink a lot of water. Otherwise you are going to cause constipation, because you've got this large amount of fibrous tissue with no water to absorb, so it just becomes a cement, harder cement. And you need to take lots of water with the bulking agent. Okay, your saline or osmotic laxatives, these are like your main ones that you go to for someone that has constipation. So you think they've got constipation, you'll generally go for an osmotic laxative. Okay, so what they do is they bring in a non-digestible, so essentially substances that can't be absorbed, or substances in huge amounts that the body's not going to take a lot. If by taking half of a certain substance, like milk and magnesium, you're still going to have a large amount to draw fluid into it. Okay? It is the main principle of osmosis. Okay? So osmosis isn't like diffusion, it's actually the opposite. It doesn't move from a high concentration to a low concentration, it moves water into a high concentration of ions. That's essentially what osmosis is, and that is what we are looking at, that is what we're trying to exploit when we're using these laxatives. So your most famous ones you can take orally, milk and magnesia, Gerber's salt, or you can take your polyethylene glycol, they're quite common. Now if these don't work because the constipation is too sustained, then you essentially can go for your enemas. Now the advantage of obviously going for the enemas, like sodium citrate, is generally speaking the constipation is at the far end of the actual bowel. So taking it orally works on the pretense that the fluids can actually get down to the area that's affected. Most of the time it works behind it. It doesn't have a stimulant with it, so it just works around it, trying to allow your body to naturally increase peristalsis by pressure. Sometimes it doesn't work, sometimes the plug's too big, so having an enema going the other way. Now a good trick to use if someone needs an enema versus somebody taking an oral is their ability to pass wind. Okay, so if the person has the ability to pass wind, essentially it means that the gaseous that are being produced can still pass over the top of the constipation, actually dropping the one-way valves in order to come out. If they can't pass wind and you've got bloating and that sort of thing, then it's a good indication that your large bowel is stretched to its maximum, and anything you put into the top is just not going to reach. So you need an enema from the bottom. Okay, so that's your osmotic laxatives that you can use. Okay, you used to use hot soapy water, that works as well, but anyway. From there, very common one, again, as your first line. Okay, someone comes in, complains of constipation, you think it's reasonable, haven't gone in a couple of days, haven't taken laxatives before, then you can give them things like Dolcosate. What it does is it will actually be absorbed and then go down to the actual area of the constipation and increase the amount of lubricants around the feces itself, allowing it to slide through the actual large bowel. So usually works best in conjunction with a stimulant if you have a block, but you can take Dolcosate orally, or you can have those glycerol suppositories as well, especially for the similar reasons that we talked about before. In order to get to the area, increases the lubrication and it just passes through. Okay, last one that is not used as much commonly, except in Australia when you have that Senegal ammonia, it sort of has that mixture of stool softeners and peristaltic movement, is your irritants and stimulants. So what these drugs will do is they'll actually increase the amount of secretions produced by actually irritating the large bowel. Okay, so they're a lot like an inflammatory, they increase the inflammatory process within the large bowel, which pushes more fluids into the bowel and at the same time increases peristalsis as well. So they're pretty clever that way, and essentially work by pseudo-stool softening and increasing peristaltic action. Okay, so they're not a bad one to choose, but usually slightly more aggressive. You need to be sure that someone hasn't taken a laxative in the last 3 days before you just jump straight to these ones. Okay? Yeah. The reason for that is, as mentioned before, across the greater population, laxative abuse is the most common cause of constipation. Now that seems very, very strange the first time you hear it, because laxatives, all these things we just talked about, are great ways to prevent and treat constipation. But what happens is someone will take a laxative, which will empty them, and then their usual routine of going once a day is prolonged because the large bowel needs to be filled. People misinterpret that as a need to take another laxative, okay, prolong it. And also, as you lose that large amount as it goes out, you lose all the water and all the electrolytes from it, which encourages the release of aldosterone, which in turn slows down peristalsis, and then you misinterpret it and take another laxative. Okay? Now, to make it easier to understand, here's a picture. Everybody loves pictures. Words don't mean much. So at the top represents your normal function. You go to the toilet and you have a normal amount of time before you start feeling the urge to go again. So it's usually just the descending colon and the rectum that is actually emptied most of the time. That's it. Rest on gravity principles. That's usually what is emptied when you go to the toilet. And then the urge to go disappears. If you take a laxative, that increases a whole lot. So I'm not talking about a bulking agent, I'm talking more about the stool softeners, the stimulant or something like that. You'll empty the entire large bowel. So to fill it is obviously going to take longer. If you don't wait, if you're not patient, and you take another laxative, then before any water, any sodium or any potassium is absorbed by the large bowel, you lose it all again. Now the loss of water and sodium activates as a feedback system the release of aldosterone from the adrenal glands. And aldosterone is responsible for storing, holding on to water and sodium. And as a byproduct of doing that, it excretes more potassium. So now you've lost twice the amount of potassium as normal. So that causes the whole body state to be hyperkalemic, and hyperkalemia, obviously being one of the main ingredients in muscle contraction, slows down peristaltic action, which in turn makes it longer to feel the bowel, to feel the urge. So then someone takes a laxative again, and it's just that vicious cycle as it goes through. If it continues for many years, then people will become dependent on laxatives, and then the body stops working until they can actually take something to increase the peristaltic action or the looseness of the stools artificially. So something else very important to educate patients on, or people you know and love on, is the use of laxatives and whether or not it's appropriate or not. Things like bulking agents, Osmotic, no problems. Okay? They're not causing this problem. They're not causing the increase of emptying the bowel quicker. The other ones, just got to be careful of. Too easy. Any questions on that? Too easy. It is indeed. Rightio. Moving on, we're getting there. Now, we know absolutely nothing about diarrhea. We don't see it enough here to actually be any good at it. Okay, so we'll cover a little bit on it. Okay. Now, I know all of you have listened to that podcast that is like 48 glorious minutes on just diarrhea alone. So we're not going to go into that sort of detail here. And as mentioned, we're not going to mention any of the antibiotics or therapies that are utilised. Just as a recap, diarrhea is caused by obviously too much fluid in the bowel. So either not absorbing enough fluid or too much fluid in the bowel. It has 5 main causes. I've lumped a couple of 2 here, but essentially there's 5 main causes for it. It's your toxins, the increased inflammation, increased fluid into the bowel. Obviously your microorganisms, most popular, believe it or not, even though we don't see it much here, is your norovirus. 40% of microbial diarrhea, all diarrhea, is caused by your norovirus. And then you've got your other perpetrators. Okay? We have people that have taken antibiotics and they all of a sudden gets what's known as colitis as a result of a certain antibiotic that they've taken, which we'll talk about. And then there's essentially the blockage in the bowel. So the blockage in the bowel is not constipation, but it's essentially if you have a benign growth or something like that that blocks things like lymphatic flow, then you have a build-up of hydrostatic pressure around an area of the bowel which causes fluid to pour into the bowel, causing diarrhea. And that obviously is not as common, but it's something that sort of needs to be considered. Now, the treatment for antidiarrheals, not antibiotics, essentially really needs to be weighed up. You can't just give the antidiarrheal willy-nilly, because obviously it can have certain side effects associated with it. So, general rule of thumb, non-microbial diarrhea for 2 to 3 days. Okay, so diarrhea that is associated purely with a change in diet, inflammatory processes, mediators, things like that, you can relatively safely take it for those ones. The problem with that is you need to determine if it's not a microbe before you give it. So sometimes it's quite difficult. If you know that somebody's got it as a result of a pill that they're on, or somebody's quitting smoking, therefore chewing a huge amount of chewing gum, things like that, then you can generally take it. Okay, someone has chronic inflammatory bowel disease or things like that, Crohn's, then you can give it to them as a supportive agent, that sort of thing. Okay, but a lot of things that aren't known about the antidiarrheal agent, obviously the main one, Imodium, loperamide, that's the one that is used, is actually, it's an opioid derivative. Okay, so that's what Imodium is. It basically slows down peristalsis so much that you increase the amount of fluid that's absorbed in the large intestine. So it's encouraging the capture time of fluid in the large bowel. That's what Imodium does. Same way if you take opioids, you get constipation. It's the similar effect. The difference is it's 40 to 50 times more potent than morphine in the slowing of the bowel. Luckily, so it doesn't kill you, it has horrible penetrating ability within the CNS. So you don't get any of the associated CNS depressant that you'd get from opioid overdose because it essentially can't penetrate the CNS. It just works on the bowel. So that's really lucky. Okay? Now, its half-life is around 11 hours. And the general way to take it is to take 1 or 2 tablets for starters, followed by a tablet every loose bowel, and but no more than 8 tablets a day. Okay, so we all know that. Now, if you have toxic megacolon, which we'll talk about, this is something that you definitely do not want to take. If someone's ingested toxic material or has a microbe, especially a microbe that can spread through the body through the lymphatic system, like your salmonellas, especially typhoid salmonella, okay, certain classes of E. coli, those ones there, you don't want to be using antidiarrheals because every time you go to the toilet, whilst you're not getting rid of all of it, you're getting rid of some of the exotoxins and some of the microbes themselves. Taking these agents encourages growth within the bowel and then spread throughout the body. So you need to be very, very careful. From there, so as a rule of thumb, if diarrhea is caused by someone taking antibiotics, we don't give it. And the reason for that is, as we learned before, we've got all these different classes of antibiotics. Some bacteria are resistant to certain antibiotics, meaning what's left in there could be contributing to it, and it's generally the bad ones that are more resistance. Ones like your Clostridium Difficile. Okay, so 20%, give or take, of patients that have diarrhea as a result of taking antibiotics have a C. diff infection. Now the problem with C. diff is it is so difficult to kill. Okay? Very, very difficult drug to kill, and essentially it destroys the bowel and produces a toxin that causes diarrhea. Okay? So it's quite a nasty bug. And it's the main contributor to your toxic megacolon disorder that you hear about. Now, the way to treat it is to stop whatever antibiotic you were originally taking and then start them on a regime like metronidazole and or your vancomycin. So that's how we stop C. diff. Okay? So we need to be very careful. We need to get good history of people with diarrhea to find out that if they're on antibiotics, and if they are, take that stool sample to find out if it could be C. diff, and do not give local market. Too easy? Rightio. You guys are doing really good. We're going to finish up with a little bit of vomiting. Okay, everyone's favourite, cute little baby vomiting in a plane.
Can I have a question?
You may indeed cope. What's your question?
Why don't you use probiotics if you have diarrhea patient here? Probiotics, you know?
I do know. I do know what you mean. And it's not that we don't use it, so we don't discourage it. We just don't hold them. That's it. So a lot of the times probiotics is recommended, especially if you're on antibiotics or been taking a long series of it. The difference is a lot of hospitals, especially Western hospitals, don't have it as a medication that we can give out. We sort of rely on people having to buy their own. I don't personally agree with it, but that's essentially the reality. It is absolutely fantastic. So things you can do is you can encourage patients to take proper yogurt or take probiotics, things like that. But unfortunately, especially in the Australian military, we don't carry or endorse because they're still classified as a natural therapy as opposed to a medical based therapy. It's a little bit wrong. Good. Look at you. Well, let's go see the check roll one. I'm going to send every patient to you then, Kate, and you can give them probiotics for us.
We have closed.
Good job. Is it closed now? Okay.
Every single gastro patient goes to keep.
Yeah, that's it.
Gotta call her in.
We check doctor, we have it's last month for us and we have closed.
That's a shame.
The check doctor.
Relax.
Yeah, so now you're just teasing us. No worries.
We have this guy who shit himself this week.
Again.
Your turn.
Yeah. Right, yeah, so moving on to vomiting so then we can finish this off. So a lot of vomiting, pretty much all vomiting, has to pass through your chemoreceptor trigger zone within your brain. Okay, so it doesn't matter what the causative agent of your vomiting is, it needs to pass through the chemoreceptor trigger zone. Okay? Now, there's three main triggers for someone vomiting, and obviously it has three different therapeutic agents that can be used. Okay? So if we're looking at motion sickness, so obviously that's essentially movement of the vestibulocochlear, the cilia within there. It gives you a false pretense that you're moving really quick, or you have repetitive movement like on a ship. It can essentially trigger the vomiting zone, and then you feel sick. Okay. Next one comes from your prefrontal cortex. So this is your emotional vomiters, for lack of a better term. So if you see something that you find repulsive, gore, anything like that, you can vomit. Okay, but it also has an auditory and an olfactory stimulation as well. So if you smell something that is offensive, it's the same thing. If you hear something and you don't like the sound of it, like the word moist, for example, you can vomit as a result of that. Right, that all comes from your cortex down to your zone. And then the last one is a trigger from your stomach. Now this is either an ingestion of a toxin, so your body registers a massive drop or increase in acid or alkalosis, therefore has a vomiting reflex, or a huge increase on the baroreceptic pressure of the stomach has the same sort of effect with the zone in order to make people vomit. So obviously the three areas that cause people to vomit, we have three different medications, really, the classes of medications that are used. So the first one, muscarinic N1 receptor agonist, okay, that basically is helping stop that motion sickness. Okay, so scopolamine, it's an American word, scopolamine is what it is essentially associated in helping that motion sickness. Now it does have your anticholinergic side effects, okay, because it still is it's obviously an anticholinergic working on the muscarinic receptors. Okay, so anything associated with anticholinergics, that's what you get. And the contraindications are pretty standard for them as well. So a nice easy drug used for simple motion sickness, prophylactically or immediately when you feel it on a ship, things like that, you can take it. Next one, H1 and D2, so histamine and dopamine receptor agonist. Okay, there is your phenothiazines as a class. Okay, so phenothiazine, includes your very common promethazine, Phenergan, and your procopyrazine, your Stemetil. Okay, now I know what you're all thinking, procopyrazine is usually used as a motion sickness one as well, and yes, it does have crossover effect, and it is useful for any motion sickness as well as your cortex related sicknesses as well. Cool, so a lot of them have sort of drowsy side effects. Okay, and your Stemetil has a side effect of extraprimordial effects, okay, too. So not a huge one compared to others, but it still has that associated risk with it. These drugs are often used for minor sickness or sickness associated with AME, things like that. Okay, they're good drugs for labyrinthitis as well. And also use especially your procopyrazine because it has that dual effect as well. Okay, so there's those antiemetics. Now the next one, excessively popular one, is your serotonin. So your 5-HT3 receptor antagonist. Okay, ondansetron, everybody's favourite. Okay, it's fantastic at people that are on chemotherapy. Okay, it is relatively safe. Okay, relatively safe, but it does have some pretty good side effects like transient blindness associated with it. Whilst it's rare, it's still a potential, so don't just go throwing it around to everyone. Now, there's a lot of studies happening with ondansetron for those that are interested in. They're starting to suggest that it's not as good on people that don't have chemotherapy. Okay, so a lot of papers out there that says it's only effective for people that have nausea and vomiting associated with chemotherapy, and they've actually started to use it in conjunction with isopropyl alcohol as well. So what they've done is they've essentially found that people sniffing an alco wipe, okay, plus or minus ondansetron, has better effect on anti-nausea, anti-vomiting than just using ondansetron itself. Okay, sniffing isopropyl alcohol wipes, 70%. Yep, just PRN as they feel sick. Sniff it, aromatherapy, and apparently it has massive increased effects for anti-nausea, anti-vomiting. Okay, now it's relatively new in the study wells, but there has been a couple of good studies released on it that essentially showed that it had better than just ondansetron alone. Either just isopropanol or isopropanol with ondansetron was better than just ondansetron alone.
Does the alcohol have an effect itself, like smell the alcohol?
Yeah.
Does that have its effect?
That has an
No.
effect by itself without having drugs. So it's a good one in the field if you don't really want to
Yeah,
get ondansetron.
never heard that in my life.
Well, that's because it's relative. It's brand new, hot off the press, mate.
I'm shook.
You're welcome.
Fucking shook.
Okay. So, alright, so that's ondansetron. So remember, this one here works on the serotonin effects, so therefore affecting the stomach and the chemoreceptor of the brain. They're not quite 100% on its effects. They just know that it works on two areas as an antiemetic. Okay, it's one of those accident ones. Again,
Is there a time frame for that too? Like, should we wait like the 20 minutes where ondansetron to start working and then have them sniff it? Or be like, here's your pill.
no, you can have it straight away. You can basically get them to sniff it, and whenever they feel like they're going to vomit or feeling nauseous, you can sniff it again.
Wow.
Alright.
Interesting.
Okay, last one we're going to look at is one that we all use, one that's been really well published, especially in the Australian Army. So we're going to talk about it, what it does, and then talk about its side effects realistically as well. Okay, so metoclopramide is what's known as a dopamine antagonist and a prokinetic agent. So it both works on the dopamine receptors in the receptor zones, and it's a prokinetic because it increases peristalsis of the stomach, so it empties the stomach. So the main advantage of Maxilon over anything else is its ability to empty the stomach. All the other antiemetics that we've talked about does not empty the stomach, it just gives your body the ability not to care about its nausea and vomiting, for lack of a better term. So if you need your stomach emptied, things like cholecystitis, where it's actually the presence of stuff in the stomach that increases the nausea, it's a fantastic drug for it. Okay, now it has side effects associated with it. Now there's a huge notion that metoclopramide is strongly linked to your extraprimordial movements. Okay, I know particularly in the Australian Army that the risk of dystonic reaction has been quantified as so great that we need to carry around benzotropine every time we have metoclopramide with us. Okay, so just to give the numbers, I'm not saying it's ever going to change, and we're always going to continue travelling benzotropine, but just to give you the numbers associated with it. So 0.2% of people that are treated with 30 to 40 milligrams stat doses of metoclopramide have an acute dystonic reaction. Now, an acute dystonic reaction includes involuntary limb movement, so literally twitching of the arms and legs, facial grimacing, so big smiles on the face. You can get ocular gyrocrisis, and you can get a disorder known as tardive dyskinesia, which is essentially a straightening and a poking out of the tongue. It's what's known as like snake-like movements, where they flex up, tongue pokes out, and they come back in. And another one is obviously your laryngeal spasms. Okay, but a lot of the time it's misdiagnosed. We give 10 milligrams to people, and it says that what's going to happen is ocular gyrocrisis and laryngeal spasms straight up. Now, whilst they are associated risks, they're rather small, and actually a lot smaller risks than a lot of the other medications that we give. Okay? Now, one dose of benzotropine, stat dose, was able to stop the acute dystonic reactions, and there was no reoccurrence. Okay, so unlike a lot of other medications that cause dystonias, where you need to give a stat dose and then continue 2 to 3 days, metoclopramide was essentially fixed after one dose with no reoccurrence. Women under the age of 25 had an increased risk of having acute dystonic reactions as well. Okay, so there's all the numbers for it as well. Okay, so that is your last antiemetic, and that's essentially the end of the presentation as well. Any questions on GIT pharmacology?
You send it to my email.